length the LSO, and the lumbar curve is already covered by the breast. So let's add the force at this region and try to stop the progression of this curve. Now the rule says if the curve was in the opposite direction to the thoracic region, so if the structural curve or the major curve or the high angled curve was the lumbar one, and the smaller curve that's touching the CSVL and measures no more than 15 degrees or less than 20 degrees, then you'll have to think twice. Should I go for a TLSO or should I stick with an LSO? In that case scenario, no, we don't go to the TLSO option because it is still a very minor curve, compensatory curve, and we think that by the correction of the lumbar curve, this curve will resolve by itself because it was developed in the first place to compensate for the lumbar curve, which I'm already treating, and I hope that I will stop its progression, or maybe I will be capable of correcting it even, and in that case scenario, yes, your thoracic curve will disappear. Why do we prefer that? Yes, we do prefer that because for the patient compliance, it's much better to have a low profile brace rather than to have a high profile brace. Cosmetically it's more acceptable, pressure wise it's more acceptable, even biomechanical wise the low profile is more effective than the high profile, and for specific reasons that we will discuss in our lectures. So in this case scenario we're covering the full spine, so we'll go for the two curves. We'll consider the two curves as to be treated curves. For the stable vertebra, the stable vertebra here, we don't have an actual stable vertebra, and the reason is we do go for the caudal, as I said before, curve. Now we do have lumbar curve. Does any vertebra of these, or does the CSVL, does the CSVL bisect any of these vertebrae? No. So this is why we can say that we do have a stable vertebra. Nonetheless, the L5 vertebra is more or less bisected by the CSVL, so we might consider it as the stable vertebra of the caudal of this spine. More specification will be explained later on. So this is the neutral and the what and the caudal and the stable and the neutral vertebrae, and we have now recognized how we can identify if our curve is actual curve or not by means of comparing it to the central sacral vertical line. Now for the alignment part, we will do the alignment, the sagittal plane alignment and the coronal plane alignment on another image to identify the malalignment, in which case you'll draw the line, the CSVL of course, and a plumb line from the C7, and investigate the relation between the CSVL and this line, or between the posterior aspect of the S1 and the plumb line that you have drawn on the image, based on your alignment. Is it sagittal or is it coronal? In general, these are the most important criteria for now that you'll have to identify in your image. Measure the angles. For the sagittal plane, you can all what you need is again view if there is any congenital anomaly that you can see or identify, and then measure the kyphotic and the lordotic angle. And as I said in the lectures, for the kyphotic angle, the literature says you'll have to measure it from the T5 down to T12. For the lordosis, L1 to L5. And after these measurements, we add all these information together in our description of the case, and then we will start to identify the biomechanical concepts that we will use for the correction of this curve. Now, just a quickly have a look here. So this is the heart, these are the clavicles. Always look at the first rib. The first rib is nothing to do with the shape of the other ribs. From the first rib, look at the shape of the first rib, and then compare it to the second and then to the third, and so on and so forth. Here are the reps. You'll have to memorize the shape of the reps, and then the heart, and then the diaphragm. And always this shadowing, this whitish here, is a question for you to answer. What is this? Okay, you should know by now because you've took the diagnostics course. Now, the rib vertebral angle difference. Yeah, I was trying to remember what else should I talk about. For the rib vertebral angle difference, again, we are interested in the apical vertebra. Going back to the apical vertebra, shapes. And now what you need to draw is a line parallel to the end plate of the vertebra, and then to identify the ribs attaching to this vertebra, and then identifying that this is the convex side and this is the concave side. Just after that, so we have identified this vertebra, so this is the rib attaching to it. We'll have to identify 2 points at the rib to draw a line that is centered at the rib, and then again here is the other rib, another line, and then so here is the line parallel to the end plate, and this is the rib at the convex side, and I've drawn this line as well as this line. Okay, and now what you'll have to do next is to measure the length of it and to centralize a line. Draw a line from the centers of these 2 lines. Let's check our measurements. Okay, so this is good. And now again another line. Good. Good. And now line from the center of this vertebra perpendicular to its end from the center of it good. And now again this is the one at the convex side, so we'll measure this angle. So that's 50 and the angle from the other side, which is this one, that is 70, so the difference is about 20, which is just the limit of saying this is a most likely to progress curve, or it is the least likely to progress curve. So this one is just at the limit, so it's likely to progress. It's based on the measurements, if it's equal 20, so it's not likely to progress, so we will consider it as a not likely